Thank you very much. I'm Professor Gopal, and I'm thankful to Dr. Francisco Ciccarello for giving me this wonderful opportunity. Been interacting with him over the past few months, and I noticed that there's so many events that he has been organizing through the ITIM. All events have been exceedingly well done. I teach computer science at Anna University College of Engineering, Guindy campus, Chennai, India. And I have been fascinated by the way in which we need to put together, if not integrate, alternative medicine systems with the practice of medicine. There are so many interesting ideas that we have been working on. And very specifically, my approach has been based on science and spirituality. In these concerns, I'm of the opinion that, well, the electronics and communication technologies, rather than information and communication technology, have been the most important bridge between the healer and the healed. As of now, it's the same external gadgets influencing. Sorry, there was a disruption. There's a disruption in my internet connectivity. My apologies. So the electronics and communication technologies is the most viable bridge. We cannot lose contact with that kind of hardware element in the exercise. We will definitely have more to listen from the esteemed speakers who are here in terms of assistive technologies, wearable and robotic systems. The reason why I wanted to go with this particular session is that the body, the human body, can influence these gadgets either temporarily, or it's not an impulse response, but it can influence these gadgets in a manner which we might not have expected. And the expected ranges of such influences are noticed, but we still need to have a prepared ground for what I think are anomalous conditions. Anyhow, I would be happy to listen to all these lectures. I'm not planning to talk any beyond this. Nice topic: assistive technologies, wearable and robotic systems in health rehabilitation. May I now invite Irene, Calvo.
Thank you everyone for the invitation to speak at this meeting. My name is Irene Calvo, and I work in the Assistive Technology team at the World Health Organization in Geneva. I'm gonna share now my screen so I can show my presentation. Let me see. Okay, you should be able to see it. And so what I'm going to talk about just in these next 10 minutes is we're taking a step a little bit back and looking at what is the need and the access to assistive technology globally. And to do that, I'm going to start with a little of a definition, a working definition on what do we mean at WHO when we talk about assistive products and assistive technology. When we talk about assistive products, we do actually mean the product itself, but we generally talk about assistive technology, referring to the broader organization of the systems and the services that are needed to bring the products to the people they need. So we don't just look at the products themselves, but really more of all the systems that are in place to get access. I also want to give a bit of a framework to say that assistive technology and assistive products lie in the division of access to medicine and products. So they are seen as the fourth pillar of health products that are necessarily and essential for the life and well-being of people, along with medicine, vaccines, and medical devices and diagnostics. So having this a bit of a background, I'm I'm just starting to explain why do the World Health Organization work on assistive technology. There are many reasons, but the more important one is that there is actually a World Health Assembly resolution from 2018 that is urging member states to increase access to assistive technology worldwide, and specifically request the WHO Secretariat to prepare a global report on what is the actual access to assistive technology, what are the strategies, what are the challenges, in the look of an integrated approach. So that is what we've been working on for the past 4 years now. And in last year, in May, in 2022, there was the first publication of the first UNICEF and WHO global report on assistive technology that provides a snapshot of what is the access, the need, the barriers to, and the funding for assistive technology worldwide. It is the first time ever that we have data on the actual need and the actual access to any assistive technology. This work has been possible due to the creation of expert advisory groups that were advising the publication and the creation of a global report. We had 2 global consultations, 6 regional consultations, more than 500 stakeholders that review the report recommendations, 11 background papers that were accompanying the report, and we had gathered data from more than 300,000 people worldwide on their use and access to assistive technology. So it has really been a huge milestone globally on assistive technology. What I'm going to focus right now in this presentation is the data tool and the data collection that has been used to inform the global report. So one of the ways we have collected data is through the use of the Rapid Assistive Technology Assessment tool. In short, it's called RATA. It's a tool that has been developed by WHO, and it's a population-based household surveys. So it's self-reported data. So people are answering questions about their need or the use of assistive technology. The tool is evaluating 4 key areas. So looking at what is the need of an assistive technology product, what is the demand, so the use of assistive technology and the unmet need, what is the supply, so what are the sources of assistive technology, who is paying for the assistive technology, what is the distance that a person needs to walk to get to their product, what are the barriers to accessing the services, and also looking at what is the overall satisfaction with their assistive technology, with the services, and also the suitability of the assistive technology product to the environment and daily activities. This tool is again, is a population household survey, and the questionnaire is a public health code, so it is published on our website in case you want to have a look at that. We used this tool to gather data all around the world. So we had more than 300,000 respondents to the survey. We trained more than 1,700 enumerators to go house by house to interview people, and we translated the tool in 28 languages. So we had the tool and the questionnaire run in 35 countries, of which 29 countries completed a national or a subnational representative surveys. Here you can just have a look of the spread of the different countries. So it includes regions from all over around the world and countries from different income levels as well. And the data collection effort span across 2 years from 2019 to 2021. So what were the outcomes of this global effort in data collections? We now have new redefined estimates on the need of assistive products. So WHO and UNICEF estimate that there are now more than 2.5 billion people who could benefit from one or more assistive products. And we also know that with the populations that are rapidly aging, and also with the prevalence of non-communicable diseases that are rising across the world. We know this number is projected to rise above 3.5 billion by 2050. So right now, we know 1 in 3 people globally is in need of an assistive product. But we also know that 2 in 3 of the people who are older, so age 60 years or older, need at least one assistive product. So the actual need is much, much higher in an older population. We also gathered that the most frequently reported needs were for spectacles, mostly reading glasses, walking sticks, and hearing aids. If we look at what is the access to assistive technology, we can see that there is really a wide range of access among different countries. In the graph, you can see in blue the trend of access to assistive technology. In orange, you can still see the trend of access to assistive technology, excluding the spectacles, because they were the highest prevalence product. So even taking those out in the analysis, we can still see that there's a huge inequity. So countries are ranging from 3% to 90% in their access to assistive technology and services. And we can see that this access is actually reported to increase or decrease according to the Human Development Index. So we can see that there is a huge global inequity. So the access vary widely and vary with this Human Development Index, which is an indicator that it's combining life expectancy, education, and gross national income in a country. So we can see that the countries who have a very high Human Development Indicators have been reported access of 87.7%, while the lower Human Development Index countries have a much smaller access of 10.7%. This inequity, of course, is also depending on what are the sources and what are the funding for assistive technology. In this graph here, we can see that in all of the countries, most of the users get their assistive products and their services from private shops and clinics, and they need to pay out of pocket. So they need to pay themselves to access the services or the products they need. This, of course, is creating those global inequity that we've seen before, and is creating a barrier to access assistive technology. The barrier, in fact, are reported to be high cost as the first one, lack of support, and also low availability of the products. So these are the most commonly reported barriers for people in need to get the assistive products and the related services that they need. This is just an overview to let you understand what is the status of access to assistive technology worldwide. All of this data is available on the Global Health Observatory website, which is the WHO website, where you can find all the different indicators for each of the different countries who participated into the data collection. And I've just listed here a list of publications and tools that are related to the work we're doing on increasing access to assistive products and assistive technology. And I also want to encourage you, if you're interested in increasing access to assistive technology worldwide, to join the GATE community. It's a community of different experts, networks who are interested in or working into assistive technology. I think I'm going to stop here for the presentation, but we also want to give thanks and recognize the work of the contributors to the report, and also to all the people who were involved in the data collection and in the global consultations. Thank you.
That's very nice, crisp presentation. Irene, thank you very much. And a simple question that I have is that the statistics are fine based on survey, but then what are the languages, 28 languages that you have been talking about? All European, or how are the interrelationships amongst the languages?
No, all the languages were the national languages of all the countries that I showed before. So it's the different, I'm gonna show the slide again here, yes. So it really all the languages from all the different countries. So it's not really related to the high income countries or like mostly European countries, but it's really related to the specific of each country. So
okay,
here.
That's nice. And is there a metric that tells how much contact is there for the assistive technology with the human body?
It's
how much contact?
That's
some
so,
metric.
Yes, so that was not a question that was included in the questionnaire. This was really more of a data collection effort to understand the global access. So not really going into the different specifications of the different assistive products. So that's not, that was not investigated.
That's fine. Thank you so much. I think it's a very, very valuable study, and coming from the World Health Organization, it's very, very crucial to understand that. And may I thank you on behalf of the organizers for a nice, crisp presentation, and request. Alexandra has already spoken, I guess. Alexandra Sojic.
No, I want to thank Irene for this general overview and the results of this questionnaire, this survey of the technology for assistance. But this technology are very close to the sensors and to the digital smart media. And we can speak, Irene, of a digital assistive technology, because many people for assistive use even the smartphone or other sensors in digital way, and we can move of the traditional assistive technology, like the wheelchairs or other important mechanics and mechatronics systems, to the digital new systems as sensor robotic systems. And it's very interesting to introduce this new product in the assistance without passing from old to new, but go directly to the new systems, very more powerful and useful for the people with the disability and fragility.
That's nice.
So,
yes,
Dr. Are you agree, Irene?
Yes, sorry. Yes, no, absolutely. And if I may add just one comment on that, I think, again, when we talk about digital assistive technology, we might directly think about the sensors, the apps, the mobile phones, all those different products that are digital products that can help facilitate any function in any areas. But I think in addition to that, if we talk about digital assistive technology, we can also think about the digital services that are not the product itself, but that are facilitating the provision, for example, the supply of products directly to the person who needs it without having to go through a rehabilitation hospital, a tertiary level, etc. So I think it's the digital services as well that can bring a really big step in increasing the access to assistive products, not just with the products themselves, but really all the digitalization of the services around them that could really make a big important factor in increasing the access. Absolutely.
Thank you.
Thank you. May I now request Dr. Alexandra Sojic?
No, Alessandra spoke before.
Spoke already. Yes, you mentioned
Already.
that. Yes, you're right. So,
Clara
Clara.
or Fiorucci, well, what do you want? You have two other speakers.
I would rather go by Cristina Fiorucci.
Cristina. Okay.
May I invite Dr. Cristina Fiorucci? Hello.
Sì, sì.
Hello.
Welcome.
Hello.
La professor Sicurello, la mia presentazione è in inglese come lingua,
E tu parli italiano.
ma la esporrò in italiano se va bene.
Thank you.
Ok.
We translate
Thank you very
later
much
to
for you.
Professor Gopal.
No, se ci fossero domande di approfondimento posso coinvolgere eventualmente anche la collega Diana, è perché non ero pronta a farla in inglese. Allora,
Bene. Salve, Diana.
condivido. Eccoci qua. Allora, grazie. Aspettate un attimo che è andato all'ultima slide.
Sì. Ok.
Ok, adesso ci siamo. Benissimo, allora grazie, sono Cristina Fiorucci per coloro che non mi conoscono, lavoro in una società di bioingegneria che è BTS Spa, una società che si occupa prevalentemente diciamo di analisi del movimento. Quindi il nostro core business è la realizzazione di sistemi di alta precisione per la misura del movimento. Nello specifico oggi parlerò di una soluzione o perlomeno l'approccio che noi abbiamo dato alla soluzione di telemedicina, di teleriabilitazione che abbiamo realizzato. Vorrei fare uno scenario diciamo iniziale e vorrei dire che inizialmente la riabilitazione motoria e cognitiva è sempre stata un po' interpretata come il far eseguire degli esercizi al paziente che si trova a casa, il tutto senza alcun governo da parte del terapista e proprio nel migliore dei casi con un controllo sporadico in differita. Quindi in pratica si trattavano di esercizi di mantenimento. Oggi riteniamo che non si possa più semplificare in questo modo la teleriabilitazione, perché il servizio di teleriabilitazione deve essere proprio tradotto nella pratica quotidiana come il fare riabilitazione, indipendentemente che il paziente si possa trovare in un centro clinico o a casa. Quindi le due modalità devono, eccole qua, le due modalità, quindi presso la struttura piuttosto che a casa, devono assolutamente coincidere perché non può esistere una riabilitazione di serie A e una riabilitazione di serie B. Se vogliamo cogliere veramente la grande opportunità di riabilitare il paziente a distanza, dobbiamo far sì che questo processo sia tale. Quindi la prima esigenza dal nostro punto di vista va a toccare l'infrastruttura, perché se è vero che oggi i servizi in cloud sono facilmente disponibili, oggi si parla spesso di servizi in cloud, non lo è altrettanto per il servizio informatico, per il servizio informativo, scusate, che deve supportare un po' tutto il processo così importante e, mi permetto di dire, delicato, allo stesso tempo rispettando diversi livelli, il livello di sicurezza, il livello di controllo, di monitoraggio, che oramai da anni in sanità sono assolutamente richiesti. BTS Telerehab è stata proprio sviluppata all'interno di servizi AWS di Amazon, quindi sfrutta il cloud di Amazon. È assolutamente conforme al regolamento europeo per la tutela e la sicurezza dei dati, per la prevenzione della perdita e della loro diffusione indesiderata. Abbiamo inserito il codice OTP per l'autenticazione del paziente quando è in televisita e abbiamo inserito la tessera sanitaria proprio per riuscire ad autenticare il paziente durante la seduta di teleriabilitazione. Tutta la soluzione, diciamo che il sistema che va a casa è completamente plug and play, quindi non è già comprensivo di internet e quindi non richiede alcun tipo di competenza informatica. Ciò che abbiamo fatto, abbiamo voluto un po' ridisegnare un po' il processo di riabilitazione che accade normalmente al paziente. Quindi il paziente viene inquadrato in clinica, quindi le informazioni, le nuove informazioni vanno ad alimentare la scheda tecnica, quindi la cartella clinica del paziente, la cartella sanitaria del paziente, scusate. Il paziente inizia così un suo percorso di riabilitazione in clinica, acquisendo consapevolezza, conoscenza sulla piattaforma. In pratica viene un po' svezzato, diciamo, all'esecuzione di questi esercizi e di questi test. In questo modo, quando lui andrà a casa, lavorerà in un ambiente a lui noto, quindi non troverà particolare difficoltà. BTS ha proprio lavorato per abbattere tutte le complessità informatiche. Il kit che va a casa non ha neanche la tastiera, quindi il paziente si deve semplicemente autenticare con la tessera sanitaria e questo è fondamentale perché è importante autenticare che cioè certificare che quel paziente è la persona che sta facendo il processo di riabilitazione. Con il modulo della televisita o del teleconsulto, invece, il medico potrà garantire poi tutti i follow-up sui pazienti cronici, quindi gestire le consulenze specialistiche e gestire il servizio di televisita su tutto il territorio, quindi abbattere un po' anche quelle che sono le barriere sul territorio. Oggi noi abbiamo una grande fortuna che probabilmente teniamo un po' poco in considerazione, perché oggi esiste un forte legame tra l'innovazione tecnologica e la richiesta di strumenti innovativi. È una condizione ideale del mercato dove c'è una grande offerta ed una elevata richiesta. A tutto questo si lega che cosa? La crescita professionale. Cioè noi oggi abbiamo bisogno di nuove competenze, quindi andiamo anche a toccare quello che è un ambito importantissimo, cioè la competenza delle risorse. In linea proprio con questo emerge il legame quindi tra la ricerca, l'innovazione tecnologica, l'industria e la riorganizzazione aziendale, perché questi processi vanno a toccare pesantemente proprio la riorganizzazione anche all'interno delle strutture. Quindi sviluppare nuovi sistemi utili a migliorare il processo di cura del paziente, andare anche a lavorare sulla riduzione dei costi di gestione, costruzione di un sistema efficace e compatibile con il servizio sanitario, questo è fondamentale. E parallelamente monitorare anche, se si vuole dire produttività, anche quello che è l'attività all'interno della struttura. Ovviamente questo sistema, diciamo, è un po' più sofisticato rispetto alla normale gestione, quindi rispetto al passato, richiede uno sforzo culturale alle persone che subentreranno in questo processo e di conseguenza richiederà anche una crescita professionale su queste figure. BTS si è posta l'obiettivo di garantire continuità nel trattamento. Riprendo un attimino i punti che ho appena espresso. Integrazione nella cartella clinica degli ospedali. Un servizio di programmazione, di schedulazione e di programmazione. Sicuramente il rispetto dei processi a livello di sicurezza. Abbiamo cercato di lavorare sull'accreditamento di questo servizio. Un sistema semplice, molto semplice deve essere. Quindi poter toccare sia la riabilitazione motoria che quella cognitiva e poi la terapia a specchio. Questo, diciamo, è quello che abbiamo cercato di raggruppare all'interno del nostro processo. Ecco, ho sintetizzato, spero di essere stata sufficientemente chiara e vi ringrazio molto per la disponibilità e l'attenzione. Scusatemi se l'ho fatta in lingua italiana, però qualora qualcuno volesse magari approfondire, magari possiamo scriverci o comunque possiamo, diciamo, inserire anche la collega Diana.
Perfetto. Grazie.
Grazie a voi.
Thank you. I have a simple question. It's good to listen to the definition of rehabilitation out here. What the patient does in the hospital, they should do in the home. Now, is it so well tasked? Are the tasks given for the motor skills, the cognitive level, so well defined so that they can go and do it at the same at home? Or did I make myself clear, ma'am?
One moment, please. Professore, posso inserire anche Diana?
Certo. Professor Gopal,
Yes.
can you repeat
Repeat.
your question?
Oh, yes, I can. It was very nice that we had a quick definition of what is called rehabilitation. Simply means that what the patient does in the hospital should also be repeatable at home. The simple question is that, are the tasks done by the patient in the hospital so clearly tasked, step-by-step tasked, so that the repeatability is ascertained?
Okay, so
Yes.
of course. Yes, so at the hospital, so this type of rehabilitation is based on the use of some little and very simple devices that the patient can start to use at the hospital, so that during the rehabilitation from a motor or cognitive point of view, the patient is supported by the clinician, by the therapist at the hospital, so that he can be confident with the use of these little devices that later he can bring with him at home, and so he can continue the rehabilitation at home with the support by remote with the therapist. So for us, it's very important that the patient can start the use of these devices at the hospital, so that for him, it's not a new thing to do by himself at home, but he has a good confidence with the use of these devices. For that, for us, it's very important to start the process at the hospital.
Okay. Thank you for joining.
You are welcome.
Very nice.
Thank you to you.
Any other questions from the participants?
Altre domande?
Hello? Okay.
Thank you.
If there are no other questions,
No.
thank you very much to both
Thank you to you.
Diana and Fiorucci. The Spanish was nice, I thought, anyway, or was it Italian?
Okay.
Anyway, thank you very much again. May I invite Dr. Clara Silvestro to make the presentation?
Hello, yes.
It so happens that the three presentations are all done by ladies, which is good. Augurs well for all of us.
Ladies.
So you can see my screen?
Yes.
Perfect. Okay, thank you, Dr. Gopal and Dr. Sicuriello for the invite. So I'm Clara Silvestro. I'm a biomedical engineer and I work at Tyromotion, which is a company that manufactures devices for the robotic and sensor-based rehabilitation. And today I'm here to present to you the potential use of our eye system in the context of wearable devices that can be used to motivate the patient to self-train at home, but also when not supervised by the therapist. So just to give a small background, if the slide is moving, okay. We know that talking about upper extremity rehabilitation from literature, we know that unfortunately many patients leave the hospital with remaining impairment, and around 40% of patients have a chronic impairment. And as we can see from this slide, unfortunately, even long after for instance, the stroke, we can see that a lot of activities of daily living cannot be performed with both arms, but mainly with the unaffected arm. So roughly 50% of the patients cannot pour a coffee or eat or go to the toilet by using both hands. And this loss of function is also perceived as a major issue by most of these patients. So even the ones that have recovered a good motor ability back. So in this context, we decided to develop a wearable device that could support the active independent training of patients outside of the conventional therapy sessions. So the eye system is a CE marked medical devices, and it consists of these trackers that can be worn at the wrist of the patient, which are able to record the arm activity throughout the day. So how the system works is there is it's IMUs as a type of device. It's collecting data out of movement. There is a smart algorithm that is, of course, detecting the arm activity with respect to, for instance, the cyclic movement of the arm, for instance, while walking. So the idea of this device is to measure the amount of arm activity and to, let's say, support the patient to do more activity with their paretic arm by giving haptic feedback, so vibration. So when a lower amount of activity is detected, it will vibrate to remind the patient, hey, you should start moving. And the device is working in combination with either a tablet in the clinic or with a smartphone when at home. And with this app that is integrated, the patients also receives notification with examples of activities of daily living he could perform with the affected arm. So in this way, any gesture like drinking, buttoning a shirt, opening a door, anything can become part of therapy. And the idea is to collect this information, which can allow also the therapist to properly plan and customize the therapy to the patient's abilities and also his weaknesses. So we have two versions of the system. One that is can be used in the hospital, which is the Arise Pro system, which is including two trackers, one for the paretic limb and one for the healthy limb.
and the system can be paired via Bluetooth through to a tablet. And the therapist, the doctor, can use the software to organize, to have the two patient databases, so to assign trackers to the different patients, and to see all the history of activity in the different days, weeks, months of therapy. And in particular to compare, as we have two trackers, the activity of the paretic limb with the activity of the healthy limb, which could be a sort of, let's say, reference value of activity. So in this case, the therapist can give targeted feedback to the patient while they are in the clinic, but as they are not supervised all the time during therapy, when they have a session, they can just simply synchronize the data of the tracker and just review the data and just see, oh, I saw that at lunchtime you're only using your healthy, for instance, side. Please try to take at least 3 bites, 5 bites with your paretic side. So to give feedbacks to encourage the patient to do self-activity. And then the idea is that when the patient leaves the hospital, is discharged, we have a version which is the Arise.me, which is consisting of a single tracker for a simplicity, which can be paired with a smartphone and can be used at home. So it's very easy to use. This, you just download the app on the smartphone, and it's paired via Bluetooth to the tracker. And the other interesting thing is that I don't need to take the smartphone with me all the time, because the sensor has an onboard memory, which can hold up to 1 year of data. So I can only synchronize the data whenever I feel up to. It could be once a day, once a week, whenever I want to. And I also have an automatic calculation of my daily target of arm activity on board of the sensor. So this allows me to, let's say, to have all the information for reminder I need already on the tracker, and I can see by just pushing the button, I can see through the use of this LED that light up what's my status. So if I have only one LED turning up, it means I'm only at from 0 to 25% of my daily target. If I have 2 LEDs, 50%, and so on. So I can know if I'm close to reaching my target, even without having the phone with me. And the overall idea of the use at home is to encourage the arm activity, is besides you having this vibration and this notification of with suggestion of arm activity, is to encourage the movement by means of gamification. So the idea is with each movement of the arm I'm making, I'm getting closer to achieving my daily targets and my activity goals. And when I reach these goals, I can collect water drops that can be used to water the so-called tree of recovery. So the tree of recovery will grow, as you can see in the video, and bloom, and there will be animals coming and so on. So the more activity I will do, the more I will recover, the more this tree will flourish. And the idea of why let's say for us it makes sense to use this arm activity trackers, as we said, unfortunately already in the inpatient rehab, most of the time patients are unsupervised, are left alone because they're sleeping or they don't have therapy, and the clinical staff is occupied elsewhere. And in general, from many studies, you can see that only a very limited percentage of the time spent in the hospital is dedicated to therapy due to also organizational reasons. And when patients go home, they do they spend even less time on therapy, because at least in the hospital they have a therapist, they have hours where there is someone that is motivating them to do the exercise, but at home nobody is actively supporting them. So the idea is that with these reminders, with gamification, this should encourage the patient to use the affected limb and to avoid or overcome the learned non-use effect. And speaking about the learned non-use effect, one of the standard approaches that has been used in therapy is the constraint-induced movement therapy. So to apply a restraint, typically a mitt or some bands that restrain the healthy limb. And in this case, there is a caregiver, which is specialized and trained, that gives exercises to the patient. We chose with our eyes to use what we call a prompting kind of approach. So we have a wearable devices that is giving reminders to the patient when there is a lack of activity. So the difference in the pros and cons of these two approaches could be that for sure the constraint-induced movement therapy, for sure it's effective, because I mean, I cannot move my healthy hand, so for sure, I need to do the things with my paretic side, and there are also many studies about this. But the problem is that it's not efficient, because you cannot keep the arm and hand restrained for the whole day for the patient. It's difficult to apply at home, and it requires a professional to give exercise to the patient. Also, it is difficult then to integrate in normal daily living activities. While with a prompting approach, you can use it all day, every day. You can integrate it with any activities of daily living. You can put your shirt on, as we said. You can do whatever you want, cook, eat, and so on, and still wear the device. And the patient is independent, doesn't need a caregiver. Of course, the effectivity might be lower because I don't have a physical constraint, so I could still, as a patient, decide to ignore the prompting of the device. So still, in this case, there is some evidence in literature that suggests that this kind of approach could be useful and a valid alternative to the SIMT approach. So there are these, for instance, 3 studies, both in stroke patients as well as in cerebral palsy patients, saying that this can increase the arm activity and can have similar effect to the SIMT approach. And just to conclude, I just want to mention that with the Arise, we are a system, we are part of a U project, which is coordinated by the University of Pisa, which started in June last year, which will last 5 years. And the aim of this project is to develop an ethical and sustainable decision-making process to provide a personalized and also validated approach to monitor and to do telerehabilitation of children with cerebral palsy. And this thanks to the use of artificial intelligence. And in this context, the Arise sensor will be worn on both wrists by the kids with cerebral palsy to record the amount of activity of the upper extremity. And in the context of this project, there is the planning of several clinical studies. So we look forward to see how this will develop and which results will bring. So I thank you for your attention, and let me know if you have any questions.
Thank you, ma'am. One quick question, the haptics component.
Yes.
It's difficult in this context. How are you managing?
So the haptic, so basically what so we have these reminders, this vibration, okay? We have up to 8 reminders per day, because we don't want to also discourage the patient by giving too many, let's say, reminders or prompts of activity. This is basically done based on to achieve your daily target, you need to do a certain amount of activity. If the sensor is detecting that you haven't done enough activity and you risk of not reaching your daily target, you will start receiving a vibration. Also, the vibration will be really subtle in the beginning, so just a small vibration. And if a patient reacts immediately, then it will stop. If not, so if a patient, you get the first vibration and the patient doesn't react, it will be a bit more insisting, so it will vibrate more strongly. So still to try to motivate the patient. I don't know if this answers your question or it was a different.
Yes, it answers, but my simple concern is that, are you choosy about using it on the patients? Part replacement, are they so careful about this wrist? The people are
sorry, I misunderstood. Using it on the patient.
People,
Clara,
the patients.
tira via le slide, così possiamo vederti.
Yes, sorry. I will close my slide. Yeah, okay. Sorry, Dr. Gopal, can you just repeat? Yes. So you were concerned about the patients?
A patient who is affected by cerebral palsy.
Yes.
Is the patient so careful about the sensitive components on the wrist?
So you mean that
yes.
It could be broken, something like this?
Whatever it is, replacement of it's not so easy for a patient with cerebral palsy to manage anything on the wrist. They move and it hits. They can't control that so easily.
Yeah. So I mean, it's not so. The sensor itself, it's quite resistance in terms of risk of, let's say, jamming it against other topics. Of course, with kids, especially smaller kids, to give instruction to do tasks is more difficult. This is also why in the study, this will be based also on play activity. Let's say, so the kids will have to do some games, let's say, to interact with their hands. So in general, if it can be broken, I mean, we have also different wristband. Also for kids, we don't use this one. We use a different one where it's inserted in a pocket, which can also be twisted and put vertically on the arm of the kid to so that is less invasive or less big on the wrist of the kid. Yeah, I don't know if this really answer your question.
No, I go by your study. You know, haptics is always the person who is touched and the thing that is touching. A third fellow, it will be very difficult for the third fellow to find out. But since your trials are very nice, I think you may select those patients where it will be effective. Your discretion, I suppose.
Yeah, so you mean that they may not be sensitive enough to feel the vibration?
Yeah, it may not be.
Yeah, it could be. Of course, I mean, as with all, let's say, medical devices, it could be that, you know, if you don't get this feeling of a vibration, will not encourage you to move. You would have to just look at the phone to just use notification for that in that case. Yeah, you're right.
One concern. So the wrist moves on its own. They have no control on that part of the body. So anyway, so thank you. And Dr. Francisco and others, any questions to Dr. Clara?
Yes, I want to ask her, this product, this system is both system for helping and reminding the patient, or only in the rehabilitation, or remind? I don't and I didn't understand which is the focus for reminding or for helping the post-stroke patients.
So
in the upper limb. Okay.
Yes. So currently it's a sort of remind to move. Okay, so the focus is this one.
Remind.
As a future development, so also within this INCP project, we are also developing a so-called exercise mode. So in that case, it will become more like a tele-rehabilitation device. So it will be cloud-based, and there will be the therapist that will record a certain type of movement, and the patient will have to repeat exactly that movement, and the tracker will be will be able to measure this was done 10 times by the patient, or 6 times, or 25. But let's say, as the status of today of the sensor is just a remind to move. And that's why we'll probably have to change also product classification. It will be a class 2 medical device in the future when we will add this exercise mode. Yeah.
Thank you.
That's nice.
Thank you.
Thank you very much. And I think we have done for the day.
We finish. Asma is not here. Asma's back.
Not here, correct.
Not here. Okay. Thank you, my friend Gopal. Tade Paili.
Pleasure. Thank you for the opportunity. I'll be happy to assist you anytime. Please count on me. It's a very important area which we are working on.
Yes, tomorrow your colleague, Professor Bai, today is not able, but she will speak tomorrow midday. Okay. in the another session, in Italian session. She will be the foreign speaker. We wait her tomorrow at midday.
I'll try to be there. Good.
Okay. Thank you very much, Professor.
Thank you,
Gopal.
and good night. Good night from India. We'll keep meeting. We'll keep interacting. Nice, very good presenters. Very nice lectures. 4 ladies, as you rightly remarked. That's nice. Good.
Thank you. Nice.
Thank you. May I leave with your kind permission?
Yes, I want to remind for tomorrow morning in on-site and online modality. We start the Italian sessions tomorrow morning at 9:15 o'clock AM in National Council of Research in Milano, and we continue for long the day. And in the afternoon, if Irene want to connect, we discuss about observatory of assistive technology, inclusive technology, rehabilitation technologies, and regenerative technologies. We discuss tomorrow morning in scientific sessions, and in the afternoon we will speak about the creation of this observatory, connecting this technological observatory with the observatory discussed last day in National Health Service Institute in Rome, in order to integrate our experience with the other experience in Italy, and to in short time to create this observatory for the technology useful for assessing for the people with the fragility and disability. We wait you tomorrow morning. Thank you Thank you again to all the speakers. Very. I want Gopal. I want to collect this 6 or 7 speakers in order to produce some publication.
Yes.
Some publication. It's very interesting system discussed today about the sensors and the bio devices. Thank you again.
True. Thank you.
Thank you.
Thank you.
Thank you to all the speakers and the participants.
Matteo, tu cosa ne pensi?
Sarebbe molto interessante. Sì.
Questi e altri lavori che domani possiamo vedere, fare veramente un piccolo,
Sì.
perché è veramente interessanti i lavori di oggi.
Sì, è vero. È
Relativi
vero.
alla riabilitazione.
Certo, sul portale magari.
Thank
Certo.
you, Dr. Matteo. Nice
Thank you.
meeting you again. I'll catch you soon. Thank you.
Thank you, Gopal. It's a pleasure.